Thank you to everybody for attending today's webinar. Thank you to Henry Schein for allowing me to present this lecture on periodontics for the general practitioner, clinical decision making with the help of AI. A little bit about myself. I was a commissioned U.S. dental officer and then later worked at a community clinic. I was then a faculty at Western University, and while I was a faculty, I opened up a emergency services dental clinic, and there was something inside of me that I wanted to do more, and I decided on pursuing a periodontal residency, and currently am a board certified periodontist, and I travel from office to office. I'm also a dental director for a FQHCs. My periodontal services are bread and butter treatment. But one of the things that stays common to me as a periodontist and as a general dentist was the ability to use common sense for all treatment. Sometimes I know that word is very underrated or overrated in certain cases, but if we use common sense, we look at the big picture, we can get a great outcome, and that's what we're here for. So my objectives for the lecture are recognizing the importance of non-surgical and surgical therapy, understand how AI can help us in all facets of dentistry, identifying key anatomical factors contributing to periodontitis and strategies for management, understanding the relationship between restorative therapy and periodontitis, and assess when to preserve or extract teeth and discuss maintenance protocol for periodontitis patients. So let's get started here. So the periodontium. And when we use the word the periodontium, what are we really talking about? Well, to understand what we are really saying, first we have to look at the soft tissue and the hard tissue. So the soft tissue and hard tissue will mimic each other and they're in harmony. So when I mean harmony is that the soft tissue looks harmonious and the bone flows 2 millimeters apical to the CEJ in a patient who has a healthy periodontium. When you look at a patient, and this intraoral picture is of mine, so when you look at the picture, other than the papillas and the color, I have some pigmentation, and I'm going to talk about the pigmentation. But the one thing I'm showing here is my phenotype. And what that means is when you see a patient who has long teeth, and these are my teeth, obviously, the gingival tissue is very thin. Now, as a general dentist, I really didn't care about those things because I wasn't really paying attention. And now I understand what this really means in terms of restorative therapy on a patient of my nature. So if you have somebody that you probe and you can see the dilations, the capillaries, and you can actually see your probe visible through the sulcus, that's a patient you want to be very cautious with. And what I mean by that is if you're doing restorative therapy, or even if you're doing cleanings and you're aggressive to a patient of my phenotype, you can actually cause attachment loss. So very important to show you this picture of mine that can help you when you treatment plan. So if you look at the X-ray, the PA right here, the alveolar crest will be about 2 to 3 millimeters apical to the CEJ, and that's what your reference should be. We want to have a nice root form. We want to have PDLs, but we don't want to see widened PDLs. Widened PDLs are indicative of possible parafunctional issues. So very important to know what healthy is when we talk about unhealthy. So what does the periodontium consist of? These are supporting tissues that are, when we talk about that word attachment, the attachment apparatus, it consists of the gingival tissues, cementum, PDLs, and the alveolar bone. When you hear periodontists talk about regenerative surgery, we are trying to do a procedure, a very technique-sensitive procedure, where we are trying to form some of these missing structures. So regenerative structures, regenerative therapy involves formation of some of these key periodontium elements. The gingival complex is very unique, and the unique aspect of it is that you have to have a nice, thick gingival complex for healthy attached tissue, free gingival margin. So I put together an acronym called FAM, like family, free gingiva, attached gingiva, and the mucogingival junction. When we're going apical to the gingival margin, meaning we're going from top to bottom, we want to have a nice assortment of some nice free gingival tissue, a nice band of attached tissue, and that band is extremely important. There is some controversy in literature saying, well, if a patient can keep it clean, does it really make a difference? That's true. If a patient can keep that area healthy, regardless of how much the numeric value is, that's fine. However, literature has said that 2 millimeters is approximately considered health. Now, in this picture here, this was a patient of mine, and as you know, this patient has no vestibule. And when you have a high Fresnel attachment, you can take a look, you can appreciate the picture here of posterior to 27 and posterior to 22. You can see some nice thick tissue, but as we go anterior from 22 to 26, 23 to 26, we see that there's not a nice band of tissue, and that's more oral mucosa. So if you're delivering some kind of partial denture, we know that we need a vestibule. A vestibule is very, very important. So what does the attached gingiva really do? Well, the attached gingiva is there to protect the teeth, and they keep the teeth bound down. So it's like your thick protective barrier, just like you have calluses on your hands, you have this thick keratin. That's very similar to that thought process of what its protective function is. It does not have elastic fibers and it's bound down versus oral mucosa, where you can see on the picture of on the right, this patient I have does not have any attached tissue. So when you start to lack attached tissue, we'll use a word, periodontists use a word, or you might hear the word mucogingival deformity. So you just see an area that's always inflamed because it does not have any keratinized tissue. So just like we have different colors of pigmentations, we have different colors of pigmentations of health that could be coral pink, but just like my intraoral picture, I have a darker shade. And it's important for us to understand that if we see this, we are not to deem this as a pathological lesion. And the reason why I say this, I had a patient come see me about 3 weeks ago, and she was very, very stressed. She was very anxious, and she was a nurse at the ER. And she said, Dr. Singh, I think I have a melanoma, and I'm very concerned. Do we need to do a biopsy? But as you can see in the picture, relatively, her free gingival tissue is healthy. It's bilateral. She does have a frenum. So I assured her that as long as the changes, the color isn't getting bigger, we take a PA of the area, we don't see any abnormalities. This is just a natural color for darker skin tones of your attached gingiva. So it's always important to understand health versus something that could be a variation of health in some people. Alveolar bone, well, healthy tissues, healthy periodontium. The alveolar crest is located about 1 to 2 millimeters apical. I would say in some cases you can go 3 millimeters as well. And it always follows the contours of the CEJ. So whenever we're preparing any crowns, and we're going to talk about some biologic width issues, we always want to make sure that we go with the CEJ because our alveolar crest does follow our CEJ. It's our landmark. So you don't want to be too aggressive at the CEJ level. When people lose their teeth, they start to miss their dentition. They're not only losing the alveolar process, the alveolar crest area, but they are now getting into their basal bone. And the basal bone is the bone that is used for a lot of the all on fours, overdenture cases, because obviously the alveolar crest has been wiped down and now we have to compensate. And those are the basal bone that is used for those cases. So in this case, you can see the normal gingival architecture on the left. It usually follows that same variation of the picture of mine. You've got the gingival space occupying the embrasures. The healthy gingiva has a knife edge margin. The interdental papilla fills in nicely. And you can see that nice band of keratinized tissue. Now you see the picture on in the middle here, and as you can see, everything just looks off. We've got active inflammation, we've got plaque buildup, we really are missing some key keratinized tissues on the lower anterior aspects. And then when we lose papilla, it's very, very difficult to regrow papilla. There are some modifications we can do with our restorative treatment, but I'll have patients who will come to see me for recession surgery, and I'm very, very candid with them that if I have an intact papilla that fills in that embrasure space, it gives me a better outcome for any soft tissue surgery. If I have a papilla that is of this nature, we call that blunting of the papillas. And it's very difficult for me to raise tissues above where the papillas are. So whenever I do any kind of recession surgery, I'm very, very candid with patients of what I can and cannot do. So those infamous black triangles do pose a certain challenge to us. So we should all know this. I love this little picture cartoon on the right-hand side of the measurements. That's from the Arrestin vendors that they gave, and you can look at it. I have this in display at the hygienist's operatories, and I carry this around. I think Arrestin does a very, very good job marketing their product, and it is a good product. But when you are seeing your patients and when you do have periodontal patients, explain to them in very, very layman terms what these numbers mean. Sometimes patients don't understand it and they don't, frankly, understand the importance of it. So, basic examples, I give very straightforward examples. I tell them that once periodontal disease is very similar to having termites in the house. The termites are there, they're just eating away at the foundation, and they're just getting to a point where they're gonna eat away at that basement level and cause a lot of issues. And the analogy or the similarity to what I say is plaque is just like the termites. After a while, those plaque bacteria, those endotoxins, those red complex bacteria, whatever you want to call it, are eating away at the gingival apparatus, and they slowly penetrate into the deeper portions of the attachment to a point where now your periodontal probe has a space between the gingival sulcus and the attachment. So just a refresher here, what is a probing depth? Well, it's measured from your free gingival margin to the sulcus base. If you have recession, it's from your CEJ to the gingival margin. It's assigned a positive number. However, there can be times when patients have what we call pseudo pockets. Their bone level looks great, but they could be on medications for gingival overgrowth, such as cyclosporin, nifedipine, phenytoin, and then those aren't really true pockets because the gingival apparatus is swollen. The true measure in periodontitis, in periodontitis measurements of how a patient can be classified if they truly have perio is a combination of everything, but clinical attachment level is truly the measure from the CEJ to the base. So again, this is a picture of me. I wanted to show my measurements and where you're measuring it from. So this is a bite wing of mine. So we can appreciate that my bone level is fairly accurate to that 2 millimeters apical to the CEJ. So when you are or your hygienist or yourself are doing these number recordings, I recommend using a software. I use Open Dental at offices that I work with. There was an office today that I worked at. They use Dentrix. They're all good to me. They're all great. However, you shouldn't have to spend time adding and subtracting. Your software program should do that. So when we say attachment loss, we're referring to the loss of junctional epithelium and sometimes connective tissue attachment. And think of junctional epithelium as your first line of defense. And it's basically like a zipper on a hoodie. If it slides down, the zipper opens and the disease progresses. Always make sure, and I always give this caution to everybody on every webinar that I present or in person, whenever you're doing your treatment planning or your hygienist is doing your treatment plan, be very, very cautious that whenever you have a case that you measure, you do not treatment plan a patient of myself with these numbers as a SRP patient, because it's very important. The last thing I would like for any provider, any hygienist would be to have, if you take insurances, to start an audit process, because your numbers and your x-rays have to match. Okay. So periodontitis definition has changed quite a bit from the older classification of the Armitage 1999, where we described periodontitis as mild, moderate, severe, advanced. It's now based on staging and grading. And this was adopted by the American Academy of Periodontitis to follow the oncology model. Staging on the left side, this is all public knowledge. You can download these sheets if you need to. So staging evaluates the severity and the scope of damage to the periodontal tissues. Grading evaluates the rate of the disease progression. Grading also considers risk factors and impact on systemic health rate of progression. So if you take a look at the grading component, if you are a smoker and or diabetic, you automatically go into the grade B criteria. So that has shown to the definition has shown that we can really collaborate with our practitioners to show the urgency of periodontitis. And it's really important for us to familiarize us as providers that periodontitis is more than just looking at x-rays and looking at the probing depth. It encompasses everything. So on the left, you see a periodontal patient who has been treated. This is the older periodontal surgical treatments that were done, where everything was flapped open, tons of infected pocket epithelium were removed. In the process, you were removing epithelium, but you ended up with severe recession. However, there's minimum pockets since your reference of from your CEJ or from your gingival margin to the sulcus has now been changed and adapted, but you can see that the texture of the tissues are healthy. However, we've got significant black triangles, but the patient is stable. On the right-hand side, this is a patient who is a smoker. Now, smokers can deceive appearance on their erythema aspect because nicotine is a very powerful vasoconstrictor and it reduces the BOP, so they won't bleed as much. However, you can see that the tissues in this patient who is a smoker, there's no keratinized tissue, especially in the lower anteriors. There's generalized recession. There's tons of class 5s, abfractions, abrasions, what have you. And you've got triangles here. However, you can see that the tissues aren't as edematous as you would expect for a patient of this nature. So in the end, when we go through etiology and when we go through patients' risk factors of periodontal disease, the number one periodontal risk factor is plaque development. Patients, in very rare occasions, it could be a genetic component. They could have some autoimmune issues. But in the end, when it's all said and done, plaque left over on the gingival margin and plaque left over due to poor oral hygiene will attack both the gingiva and bone and leading to excessive inflammation, and it will be a silent killer of the teeth. There was a article done by a periodontist called Lang and Low, and they did a study in which they showed healthy volunteers who stopped brushing started to have gingival inflammation as early as 2 to 4 days. So basically within 72 hours, you can start to have plaque accumulation, which will start to present itself with gingival inflammation, gingivitis symptoms. So very important that we are always educating our patient. So there are times when I'm a big proponent of non-surgical therapy. I am a huge proponent of less is more in terms of if a patient can be maintained with a hygienist, we can use some adjunctive therapeutics. The patient might not have to go through surgical needs. This also helps us see the compliance and motivation of a patient if they really care about keeping their teeth. Now, this is a patient I worked on, and I did actually surgery on number 30 and 31. And I am extremely thorough. I communicate before the patient's treatment. We have a consultation, and I go through everything. I give them sheets and I give them expectations. And I told the patient, we're not going to have you brush or floss around 30 and 31 until I see you in 2 weeks. And they presented like this after 2 weeks. And I don't know where we lost the memo here. However, 30 and 31 failed because the plaque level, as you can see, is extremely high. And so this patient spent all this much money. We spent all this time to try to do a regenerative surgery when they came back like this. So it's very important that we know when we do non-surgical therapy, everything starts with non-surgical therapy treatment. So what else does it involve other than scaling and root planing? Well, I alluded to chemical agents such as minocycline, arrestin, putting patients on Paradex. I also put a patient in certain cases with aggressive periodontitis after I treat them on a low dose sub-antimicrobial dosage of Periostat, which is doxycycline hyclate, 20 milligrams for a minimum of 3 months BID. Laser therapy is great. I am a big proponent of all of these measures. Rectifying and or controlling local and systemic contributing factors. I'm going to talk about some local factors later on, but systemic factors such as hypertension, lack of correct omega-3s. I talk a lot about having patients add omega-3s, fatty acids to their diet, compliance program, daily self-care measures, accurate PMTs. All of those things need to be considered. So we should know non-surgical therapy involves scaling, which is removal of buildup around the crown and root surfaces, supragingival, and then root planing, like the word means, we're a little bit more aggressive at the apical root portion of the tooth, so we can remove those toxins and microorganisms. I personally recommend patients be on some supplements, such as vitamin C, D, E, B12s, omega-3s, probiotics. But I always tell patients, especially as a periodontist, I see geriatric patients and sometimes they are on blood thinners, and omega-3s do have an effect on omega-3. So I'm very, very cautious about that. And I tell them to have a candid conversation with their primary care provider or cardiologist if they can take omega-3s. Laser is a great option on those pockets. This is something that they have at the office. I'm not endorsing this laser over another. They all work great in my opinion, but this is great in some aggressive pockets on the distal of second molars. I also recommend Arrestin is great. Atridox was a product, it's no longer used. But PerioProtect also is a product that has hydrogen peroxide in it. It is a sustained release of the hydrogen peroxide, and you're chemically debriding the biofilm from periodontal pockets. However, chemical agents need to be used sparingly and they need to be used in right conditions. And I will show you a case that I saw about 3 months ago last year. This patient was a retired general surgeon, and they were sent out to me with this four bite wings and two PAs. And they said, my GP referred me because I'm having pain on my lower molars. My hygienist has been taking care of me with Arestin, and it's been great. So, as a periodontist or anybody who has any suspicion on the perio aspect of teeth, you need to take PAs. You need to take PAs because looking at a bite wing does not give you, it gives me an idea, but at the same time, I need PAs. So when I saw a PA of 30, this is what I saw. And then I saw a PA of number 19. Now, number one, I never blame any provider. My job is never to blame, never to point fingers, but my job is to educate. And this patient was treated on a regular basis per the patient. There's always two sides of a story, so I always reserve my judgment. I keep my mouth quiet, I listen more. But when you look at these teeth, if indeed the patient is correct, so this is a very, very poor treatment plan. This is extremely incorrect to place a patient on this kind of treatment when you don't take a PAs early on and you just keep on putting Arestin if the patient is correct. But unfortunately, we've got furcation issues on both teeth, and we've got severe radiographic bone loss. And as a periodontist, I cannot do anything other than remove these teeth. So it's very important that if you do use any of these agents, make sure that you document and you have a candid conversation after you take a PA of the limitations of it and also the need to see a periodontist if the areas don't get improved or you feel that you need a second opinion. So, patient self-care, I am a huge fan of water picks. It's a part of my daily routine to tell patients. I also tell patients on top of using a water pick, if you don't like flossing, please use proxy brushes. Please use Peridex as well. And if a patient is adamant that they are cleaning their teeth and they're coming with extreme plaque, I also carry plaque disclosing tabs, and I'll have them chew them in front of me and we both go over it together. I love Peridex. I do a pre-surgical rinse with Peridex. However, Peridex does have some risks as well, and the one that we know about is the staining, and then it can cause additional calculus. But the one I care about is studies show that it disrupts fibroblastic activity. Fibroblasts produce collagen, and collagen is very important for the production of connective tissue and bone. So whenever I do any surgery or any treatment, I have the patient start Paradex number one 3 days after my treatment, and I have them on 3 weeks because extended periods of time have seen patients have disruption in their bone formation. So you've kept the patient, you've explained to them, and you've explained to them what they need to do, and you have seen the patient for a perio re-eval, and you see a patient went from the left to the right where minimum swelling, excellent oral hygiene, decreased mobility, and you've got a pocket depth of less than 5 millimeter. In certain cases, I actually am fine with 5 millimeters. However, there should be no bleeding, and I accept 5 millimeters in the distal of a second molar because that's a very, very hard area to treat. So if you have a 5 millimeter and you're not getting any improvement, then I sometimes recommend to get a consult with the patient. But 5 millimeters on a distal of a second molar where patients have had third molars removed and they've had a defect from there, it's a very challenging area to get good bone fill. As long as it's not bleeding, we can do some adjustments in that area. Maybe the patient is biting too hard and there could be some parafunctional issues causing it. I'm fine with maintaining this patient, maybe getting him some arrest in, things of that nature before I go into surgery on a second molar. So 4 to 6 weeks later, sometimes I'll get referrals, doctor saying patient had SRP 2 weeks ago. We want you to re-eval the area. I'm not going to be able to give a definitive diagnosis because the gingiva is changing and shaping according to the health situation. You do have some outcomes that we tell patients that you can get now sensitivity. The teeth will initially slightly be mobile, but they will, over time, the attachment will improve, and you could get some recession. But at the same time, it's always good to have these conversations sooner than later. Re-eval, make sure you update the medical status. You never know how many people say, oh, by the way, oh, now I'm on warfarin. Oh, I'm on Plavix. Oh, by the way, I am getting knee surgery and I wanted to know, can I get a cleaning within 3 months of my knee surgery? So very important. Make sure you update the probing depth, BOPs, cal, recession. Your computer software should do that and compare the results. And if you see areas that aren't responding, it's good to have a candid conversation for those non-responsive disease sites. So that's a patient on the left who had an SRP, and clearly they came to see the hygienist after 6 weeks, and you could see there's plaque on number 2, 3. And the hygienist asked me, he said, Dr. Singh, what do you think? I said, what do you think? And she said, I don't think this patient's going to have a good outcome if you do surgery because they don't understand oral hygiene. I said, I totally agree with you. So this patient goes back again to the non-surgical therapy. And if they don't understand the severity of their situation, I put it back on the patient. On the patient on the right, the patient had a cleaning done. The gingival margin, the gingival tissue looks fairly nice without minimum edematous tissue. However, there are residual pockets, and now they will be a candidate for any treatment that might surgically be involved. Periodontal maintenance, not going to spend a lot of time with that. Active perio patients, 3 to 4 month surgery, 3 to 4 month PMTs. However, some patients' insurances dictate that, and I always tell them, irrespective of your surgery, irrespective of your insurance, you should come at least a minimum of 4 months. If you can't, it is what it is, but 6 months should be the next option. When you're doing a PMT, you got to be a little bit more aggressive than doing a prophy because that's really not PMT. So let's talk about AI in dentistry and how it can help all clinicians, including myself. And I use AI in my treatment plans. So there's research is showing that 64% of patients really don't understand their x-rays during consultations. And when you have an extensive treatment plan, let's say a patient hasn't come to see a dentist in many, many years, and now they're coming in, they are coming in to see the provider after years of, let's say, financial situation, or maybe they weren't educated enough and now they really want treatment and they really are caring about getting their dentition in order. A lot of collaborative treatment plans where you have restorative, endo, perio, oral surgery, it can be very overwhelming. And when you throw this knowledge at patients, sometimes 64% of them have said they don't understand their x-rays. 55% say trust in the diagnosis is the most important factor in treatment acceptance. 40% say they distrust dentists. Now, dentists have got a bad rap for many, many years. And the way the world is going, from ChatGPT to Gemini to all these programs, I am glad that AI is getting involved in dentistry, because when it's presented in a AI version, when AI looks at your x-rays, a patient's x-rays, the proof is in the pudding. And I use this software, Pearl Second Opinion. I think it's phenomenal. Second Opinion is FDA cleared to assist in detecting a wide range of issues. So when you have this program in your office, and I highly encourage people, providers, to start incorporating AI, it will detect within a very high level of accuracy incipient caries, which are in yellow. Then it will have pink, which is the caries that need to be treated, calculus in green. It will have open margins in your blue, and then it will have, I'm sorry, your notable margins will be in that purplish blue shade. Your periapical radiolucencies will be in blue, and then it gives me bone loss, which I love. So here's a patient that you can see. If you have just the left-hand side, you can see the calculus there. But when patients look at their x-rays and they see these colors and there's a computer program, it is a huge benefit in your treatment plans because you can magnify this and the computer software is giving you comparable numbers to your periostatus. And I've looked at their numbers and I am pretty on point with what they're saying. So when you use this, I have this up in front of the patients, and I highly recommend everybody to scan the QR code here. It will give you a insight into Pearl software, and you can set up a demo with them. I think it's phenomenal. I'm going to show you. This is a patient that I saw last week, and I'm using Pearl. I'm not sure if you hear it, my voice in the back, but I'll just talk over it. So, Lisa, are you able to hear the noise of the volume?
No.
Okay, so I'll just talk over it. So this is a FMX that I opened up using Pearl, and then they said, Dr. Singh, this is a comprehensive periodontal exam that you need to do, and AI picks up their caries, and then it's giving me what I need. It gives you the bone loss and percentage, and I can toggle that into millimeters in a little bit. And right there, I click on the millimeters. So I have an idea of, well, that's green is fairly healthy. I want to be 2 millimeters apical to that CEJ, but I also help out the general dentist as well if they've missed anything, because I was a general dentist and I give the general dentist information too. So this was a case a couple of months ago where they said, Dr. Singh, we need you to do a consult for a possible crown lengthening on 19. I looked at the bite wing. I always tell my staff, I cannot make diagnosis from a bite wing. I need a PA. So let's use Pearl to see the condition of the root canal. I can see some gutta percha, and this is what pops up to me. And the patient goes, that doesn't look too good, does it? I said, you see what I see. We've got an open margin, recurrent decay, we've got frication involvement, we've got extreme bone loss into that furcal area, and this tooth I couldn't save. So I use this as a periodontist, and I help out my practitioners. I think it's a valuable tool, and I highly encourage people to use it. So let's talk about local risk factors here. Furcation is the big one. I see a lot of patients where they have furcation involvement. I was at an office today. I did a consult on two furcation cases. One of them was an abutment for a FPD, a class 2 furcation. This is the Glickman classification. This is a cul-de-sac horizontal component. The other classification is this is more of a objective. The hemp classification is the other one. This one's a subjective one. The hemp HAMP is the objective one, where you basically use a neighbor's probe and you can probe 3, 6, and then 9 increments of the furcation if you have that probe. But this gives us an idea right here. You have a grade 1, grade 2, grade 3, and a grade 4. When you have grade 4, you're usually looking at an extraction of this tooth. Grade 2, depending on the situation, you can maintain it with a SRP, non-surgical therapy. But if it's being the same or it's getting worse, surgical intervention. Now, greater efficiency and efficacy is seen removing plaque when you're doing furcation sites with a Cavitron or a slim tip with your piezo, whatever you want to use, ultrasonic, but you gotta use a slim tip because the reason being is that these furcation sites are very, very narrow. And this gentleman called Jan Lindy, I looked at his credentials. He's a periodontist and he's an oral surgeon. And he has stated, and this is a board question that always used to come up, never do SRPs or aggressive cleanings in pockets that are less than 2.9 millimeters because you're going to have attachment loss. So it's very important that if you have a shallow pocket, please don't be aggressive because you're going to cause some damage. Because, based on this gentleman's credentials, I agree with whatever he says because he's very, very learned. So right here, another study was done. Why is it important to use a very narrow slim tip? Well, the reason is very simple. It's because the width of the furcation is actually less than a millimeter, and our curettes are bigger than a millimeter. And so you want to use something that is extremely narrow. So if you're just doing scaling and just scaling with a hand instrument and you're not using a slim tip in this area, you're not really doing anything because it's very, very thin and narrow. So as you can see in these areas, when you're doing your restorative treatment, always be very mindful that you do not want to encroach upon the furcation area because once you get into that area, you start to put restorations in there. It's a basic plaque trap. Another aspect of a study done by Bauer is root concavity. So not only is the furcation very narrow, but the roots are concave and not convex. So what that means is when patients are cleaning the furcation area, they need to be a little bit more aggressive than just using floss. They've got to use one of those proxy brushes, those baby bottle cleaners, the baby bottle tips that you see that can go into that area and adapt. Because if you just are using floss in that furcation that's open, you're not really doing anything. And this study showed that the roots are concave in majority of the times. So as you can see, if you're not getting into that area, even on a premolar, once a premolar, number 5, number 12, they have a significant mesial concavity. So if you have a premolar that has a concavity and you don't pick it up and you don't pick up that it has a furcation and it's having some bone loss issues in a premolar, the tooth is a goner if you keep on ignoring it. Palatoradicular grooves. These happen in lateral incisors. These are fairly not too common, but I see them quite a bit. Here's a condition that we see. We've defined it as a developmental groove. And as you can see that a deep palatoradicular groove predisposes a tooth to pulpal necrosis with a combination of a perio and endo lesion. So basically it has a extra invagination and a groove. And if you have a groove that goes all the way from the cingulum to the apices, and it's showing deep pockets, but it was never addressed, you can have some serious issues. Here was a case done from one of my attendings, Dr. Al Hazimi, who is a board certified endodontist and a periodontist. He had a 15-year-old patient with a pocket of 13 millimeters. And this is truly remarkable. The parents did not want the tooth to be removed. It was a young girl. Dr. Halzimi did something that is amazing. He did an intentional extraction. He did a endo on this tooth. He applied Emdogain, which is a biological product I use quite a bit. It is an amylogen protein from a fetal pig that shows when applied in a liquid format, a gel format, it increases cementogenesis. Then he replanted the tooth after doing a great endo, splinted it, and had the splint in for about 2 months. And at 3 months recall, the sinus tract had dissolved, and at 1 year recall, there was complete absence of the radiolucency. So that is pretty amazing results. Sometimes, when patients tell me, "Oh, Dr. Singh, it worked out well," I say sometimes we get lucky and we have a good patient who is compliant. So, root proximity, this was a term that was described by a general dentist who actually did a lot of ortho. And what they're saying is if you have two teeth or multiple teeth that are less than 1 millimeter or equal to 1 millimeter, you're going to have periodontal issues. And the reason being is simply because there's a lack of vascularity into those areas. So, unfortunately, if patients have malocclusion, crowding, and it's not caught early and the roots are very close to the neighboring teeth, you're going to have some periodontal issues going on. And as you can see in this case, this was actually a patient I saw at a office where the general dentist said, "Dr. Singh, can you help out with number 31? I had to place a amalgam subgingival to close the margin, and unfortunately, you can see that not only the roots are close, but it's an extremely, extremely sub-G restoration." Third molars. So research shows that if you have a third molar removal in a patient that's older than 26 years old with mesioangular or horizontal impaction, the second molar gets affected. And I see this quite a bit on a lot of the patients that I have treated. The third molar taken out at a latter stage of their life requires quite a bit of bone removal, especially on the distal of that second molar. And what do we do on there? Well, there was studies done where it showed that if you put some type of regenerative material, what can work? And there was a big study done by Camps Font where a systematic review and meta-analysis showed that they went through all the literature, randomized clinical trials, and they showed that out of 1,200 potential eligible articles that they reviewed, they saw that sockets that were filled with either PRF or some xenogenic particles achieved greater level of maturation and regenerative results when the socket was covered with this kind of membrane. So in certain cases, when you're taking out third molars, it does help. I don't recommend taking out a third molar unless we in the early age we need to address it, but when we get to a latter part of our life, it really affects the second molar, so it's better to address it early than later. So let's talk about the relationship with periodontitis and restorative situations. So what are you trying to achieve with your restorations? I know as a prior general dentist, we want to make sure that the gingival margin and the crown margins are nice and aesthetic. They're clean, they're not inflamed. We want to have soft tissue that is nice and mimicking the hard tissue. We want to have nice porcelain color. And also, when you're doing your restorations, anything, your fillings, your direct or indirect, you want to make sure that the tissue is not severely inflamed. But the basic principle here is inflammation or trauma must be eliminated prior to restorations and not after. So there's something that we might have heard called biologic width. The name has changed to supracrestoconnective attachment tissue. And I kind of like the biologic width uh, term, but it's been changed. Now, what does that mean? Essentially, if you prep too close to the alveolar crest, you're disturbing the attachment and you're leading to a situation where you've got constant inflammation. So there was a study done, Gargiulo did this, and they looked at the numbers and they kind of said that including the sulcus, we've got about 3.07 millimeters when you add everything together, around 3 millimeters or so, that you have that safety zone. Anything that you get close to or you go past that number, you're gonna have a situation like this. So if you're prepping subgingival, in certain cases, I understand aesthetic margins in the front. I used to do that to make sure the aesthetics were nice so the margin wouldn't show. However, if you get a little too aggressive in certain cases, your patients complain that it's always red, even though they keep it clean. So how do you help patients when there is a violation? How do you even know? So you've delivered a temporary and you bring back the patient and it's always red, and everywhere else it looks healthy. Now, it could be that there's some temporary cement in there, or the prep is a little bit subgingival, or the tissues are responding a little bit slowly. So you clean up the area and you tell the patient, use a water pick, and you do all those things. You see the patient again. And now you've seen that this is a constant irritant, and hopefully you've caught this in your provisional situation. If I remember when I was a general dentist, if I had to put a lot of force when I'm packing cord and your cord keeps on coming out of the sulcus, that's an indication that you have a biologic width violation or you're close to it. If you need to send a patient to a periodontist or you're doing your treatments by yourself, I always recommend do a rough prep. Make sure if you catch it early, do a rough prep. If you know it's very deep, the margin is going to be very deep, do a rough prep. Explain to the patient in layman terms what you're going to be doing or the periodontist is going to be doing. And then based on your rough margin, we can give you the margins contoured to that. That will be the reference. But as you can see in these cases, it's extremely inflamed. The tissue is saying something is not right. Now, this patient right here, perfect example, young gentleman. If you look at number 6, number 5, number 11, number 12, doesn't look too bad at all. Nice gingival margin, minus 8 and 9. 8 and 9, things change a little bit. So the general dentist who referred it said, Dr. Singh, I think there's a biologic width violation. It's been a while now. It won't go away. The patient complains. So I said, take off the temps, take off the patient's crowns because it won't go away. Patients paid a lot of money. Let's put them in a nice temp. So when I take off the temps, as you can see, the crowns are basically sitting on excessive gingival tissue. So the tissue cannot breathe. So what we do is we do some aesthetic crown lengthening. And as you can see on the picture on the left, the margin needs to be a good 3 to 4 millimeters from the margin of the crest to the bone. So we recontour that area, we make it longer from what the margin is, and then we apically position the flap. How do we know it worked? The patient came back in a few weeks in his temp, and right there you could see the gingival margin, how beautiful it looks. It's back to health. So you know that it works. Okay. You need to remember anterior cases. You need to have some time on those cases and don't rush. So how do you recognize inflammation and around teeth? Very straightforward. Just look at the color. There's no magic to that. Look at the texture. Make a treatment plan. How are you going to do this? Avoid your restorative therapy until perio is addressed, because if you do it the other way around, patients feel that you haven't done the due diligence. I get these questions a lot as a periodontist. I try to save teeth, however, I am realistic. Dr. Tarnow is a world-renowned periodontist from Colombia. He put together some conditions when to extract teeth. Teeth with an existing crown that will need a new root canal, basically a retreat, crown lengthening, post a new crown. I agree with that. Lack of teeth structure above the crest, i.e. you have an extremely inadequate ferrule, especially in the aesthetic zone. Maybe that could be a challenge. However, in certain cases, I don't really agree with that. High chance of decay and poor oral hygiene of mouth, I totally agree. Periosurgery will cause aesthetic issues. Just like I showed you in that early picture, you're going to lose so much papilla, anterior zones. Don't recommend aggressive periosurgery. Grade 3 mobility and grade 3 furcation involvement, very challenging. In this case, I had this referral for crown lengthening, short crown to root ratio, not ideal at all. By the time I lay a flap and take out bone, I'm already compromising a very, very compromised situation anyway. You would rather have the roots longer 1 to 2 ratio as opposed to the crown to root ratio being 2 to 1. When to save a tooth? Well, you have an intact dental arch, functional restorations, low caries, little to no perio disease, tooth is not in the aesthetic zone, and a patient who has never lost a tooth and really wants to save the tooth. So here's a case that I got The referral was for short clinical crowns. They wanted to save these teeth. But as you can say, this is a case that it just doesn't have enough retention. We're going to save these teeth. We're going to do some aesthetic crown lengthenings in this case, and these are worth saving. Here's another case I did with the general dentist. A lot of caries, older gentleman, doesn't want to do the all-on-4 treatment. But if you look at his keratinized tissue, I've got nice thick keratinized tissue. I look at his PAs and 22 to 27. I've got good crown to root ratio. They're fractured, but the patient does not want to get implants at his age. But I like the crown to root ratio. There's no mobility, and the patient was motivated to save it. So we did aesthetic crown lengthening, made the teeth look longer. Beautiful preps were done. Intentional endos were done by the endodontist, and the patient got custom temps. And after a while, they healed, and the doctor, general dentist, put them in some beautiful Emacs, give them a night guard, and called it a day. So, conclusion, knowing the importance of non-surgical therapy is critical for periodontal health. Use AI to streamline your practice. Understand the complexity and unique anatomy of teeth with all the plaque retentive factors I showed you, the furcation, the palatoradicular grooves, the third molars, the distals. Restorations needing subgingival margins should be done with care and knowing when to save or extract teeth. Here's some of the locations this is one of the locations, my main location I work at. I am in Southern California. This is the QR code for the AI Pro system. I highly recommend people to give this a try. My team is Liverpool Football Club. I'm originally from England. Our slogan that really appeals to me and has appealed to me for majority of my life is "You'll never walk alone." And that's the type of mentality us as practitioners should have to help each other out. No one knows more than anyone. We're here to teach. I'm always here to learn, and vice versa. Thank you so much for your time, and I appreciate you being a part of this CE.
All right. Thank you so much. We do have a few questions. We can got a couple of minutes left if you don't mind answering a few of those for us, Dr. Singh.
Sure, sure.
Um, can you review staging perio on an X-ray with slight bone loss, pocketing from CEJ to slight crestal bone loss using measuring guide?
Um, if you're referring to I use that along with my measurements along with recession. So you cannot just measure, you can't make a diagnosis of periodontitis just from the x-rays alone. So it's a combination thing. It encompasses pretty much everything. So it's a component to help you out with the Pearl software.
What treatment is recommended for a patient who presents with irritated red gingiva, likely from mouth breathing at night?
If you're a mouth breather, then I would say you if the gingiva is extremely inflamed, it could be a combination. It would be something that, as a mouth breather, that at that point, flaring of the teeth, I would also have an orthodontic evaluation as well. But a lot of it could be from mouth breathing that your saliva, your plaque level is not as ideal. Your salivary flow could be altered, and you're accumulating more plaque than you should be. So in those cases, I would say, without having any pictures or without having the complete information, I would treat as well for xerostomia as well. I would do the orthodontic evaluation, xerostomia, biotine, some pilocarpine, things of that nature. I would also encourage the patient to be drinking a lot of water as well at all times. I mean, I drink a bottle of this water. I'm not endorsing this, by the way. This is Kirkland.
Do you switch to implant for short crown and furcation and involvement?
So in the case I showed you, in those cases, I will recommend a implant if a patient wants to go with that treatment. However, as a periodontist, I place implants. I see implants work great, but they can fail as well. So implants should be done in the right cases. If a patient doesn't want to go through an implant, I understand totally. I never convince anybody. I never sway them. My job is to educate. And I will let the restorative doctor, if they don't want to go through that, the other option is an FPD. I don't recommend it on a second molar using that as an abutment, but it's up to the patient as well. It's their mouth. They're paying for it. But an implant would be my choice in those cases I showed.
Can you speak to having an allergic reaction to metals in regards to PMFs or PFMs?
PFMs. So that's a great question. Sometimes patients do have a allergic reaction, and at that point, if they tell me that they do have a reaction, I will tell them to talk to their primary care provider for additional testing. If it is truly that, in most of my cases that I've seen, I have actually noticed, and I was as a general dentist myself, I was guilty of this myself. I was prepping too aggressive, and at the temporary crowns appointment, I would have tail signs of biologic width. And at that point, and I take accountability for my own mistakes, I should have recognized this earlier and immediately said, look, we got to take the crowns off, put you in nice temporary, and we got to get a consultation with at least a periodontist. If you've tried everything, and if a patient does have a true allergic reaction to metals, then that should be discussed early on. If when you're choosing your crown and bridge material, that should be a question that they should fill out allergies in their allergy metal, and then you should do, Emaxes or zirconias or something. But that should be done early during their treatment planning phase.
Uh, Going back to the case with a general surgeon who had very periodiseased teeth number 19 and 30, is endo treatment and then hemisection of these teeth a viable option, or is that just too old school?
That's a great question. Whoever the doctor was, that's a great, great question. Unfortunately, hemisections used to work. I mean, I went to a very traditional the perio program where they did do that. Over time, thoughts have changed. The problem is in those cases, you see excessive bone loss on the mesial and distal roots, and you've got frication involvement. So in that case, it wouldn't have worked. But that's a great point. A lot of cases I have seen from the traditional perio have been hemisections. Unfortunately, it's a treatment that it's a very challenging treatment nowadays just because of the situation of insurances and this and that and patient compliance. You spend all that time to get an endo done, you section the roots, you do perio surgery around that retained root, and then if they're not compliant, you're back to square one.
What is your opinion on deep margin elevation?
Great question. As a general dentist, I do understand the concept. I'm torn because I've seen cases where it has been done. I understand the concept. You don't want to refer to crown lengthenings and you want to avoid that as much as you can, and I get it. However, once you violated the biologic width, you violated it, and these are studies, as a periodontist and as a prior general dentist, you know, if you have a margin that's very subgingival and you're just close to that attachment, the body just doesn't respond very well. And I've seen a lot of cases as a periodontist and I see them very frequently, that once you've entered that danger zone, it's just a matter of time. It's just a matter of time. Patients are walking around, they see me after 3, 4 years after they mentioned that it's always been red, it doesn't get better. The dentist just did a localized SRP, put me on Paradex, but you can see the contralateral side, and it's perfect. I'm a firm believer that once you've violated that zone, it is challenging. But I understand as a restorative dentist, I was there.
Okay, one last question here.
Sure.
Are root amputation still done? Still performed?
Good question. They are done very rarely. And the reason is, and I'll be very, very honest, root amputations now are done because they're very infrequently done because a lot of insurance plans don't cover it, and it's very hard to convince a patient to go through that treatment when if you are I see a lot of patients with insurances and it's not a part of the treatment plan. And on top of that, patients don't really understand the importance of it. because it is considered an old school treatment.